Welcome, everyone. Welcome to the Implementation Toolkit for Months webinar, Data in Action to Drive Quality Improvement for Newborns. Welcome. Please introduce yourself in the chat. Bienvenue. Please introduce yourself in the chat. Next slide, please. Hello again. We're very excited to welcome you to our Newborn Toolkit webinar, exploring the latest in neonatal care and data for action. And this is brought to you by the Newborn Toolkit, which is a multi-country, multilingual learning for high-quality small and sick newborn care. In 2025, we had more than 62,500 unique users from 170 countries, and it's all thanks to our community all over the world that continue to make use of the toolkit. The toolkit has 1,000 tools in 15 languages, technical content in French, and linked communities of practice in English and French. And this is all to meet the national target of the SDG 3.2 for newborn survival that cannot be met without small and sick newborn care. Next slide, please. So join us today as we spotlight key insights on how we can use data to move beyond dashboards to drive real change. We'll explore data in action to drive quality improvement for newborns. And this is linked to the 10 core components of small and sick newborn care for WHO and UNICEF, data systems, and QI. This is brought to you by the Newborn Toolkit, and we host webinars and love to share news and share tools linked to small and sick newborn care. On the screen now, you will see a QR code for our newsletter in English, our newsletter in French, and you can also follow us on Blue Sky, Twitter, LinkedIn, and Facebook. My name is Mbozo Sipalo. I'm a clinical researcher, knowledge management co-lead of a Newborn Toolkit, and very happy to see more people joining. And please do share this link with more people who would want to join this webinar. Next slide, please. So our upcoming webinars on 10th March, we have a very interesting topic that is timely and necessary for our newborn wards, which is better breathing for tiny babies. What is next for antenatal corticosteroids and caffeine? And we encourage you all to share this with your networks. And on 14th April, we have referral systems and linkage to maternal care. Also, welcome you to join these webinars and more 2026 exciting webinars to come. Now I will hand over to my colleague Lauren to take us through the webinars in French and to also later introduce our host. Over to you, Lauren.
Thank you. Donc, bonjour et bienvenue à tous nos participants parlant français. Si vous voulez écouter le webinaire en français, si vous cliquez sur le bouton d'interprétation situé sur la barre de menu de Zoom pour accéder à la canal français. On a aussi quelques webinaires à venir. Donc, le 10 mars, une meilleure respiration pour les petits bébés. Quelle est la prochaine étape pour les corticostéroïdes prénataux et la caféine? Et le 14 avril, système de référence et lien avec les soins maternels. Donc, nous vous invitons de nous rejoindre pour ces webinaires. Next slide, please. And I will pass over to our host today, Dr. Abiy Seifu. Abiy is an assistant professor at Addis Ababa University, leader of Saving Little Lives 360 collaboration between Saving Little Lives and Nest 360 nationally across Ethiopia. He's a public health specialist with more than 15 years experience in design, implementation, evaluation, and maternal and neonatal health programs. So we're very excited to have Abiy here with us today.
Thank you, Lauren. Welcome, everyone. Happy to host you today. We'll be discussing today a very important topic. As you all know, data-driven strategies are central to achieving SDG targets, particularly through driving improvement in quality and safety of vulnerable newborn care. And to enable rapid decision making, modify our implementation strategies, particularly having real-time continuous insight into our data is very critical. And also to ensuring accountability of what we do in newborn health. So today we have a very distinguished panel. So we'll start with a talk on from data to decision journey through a small and sick newborn care dashboard for action and scale. And John Wainaina will be presenting this session. If you go to the next slide, please. Next slide. Yes. John is Data for Action Analytics Manager. Can you go back, please? Manager for NEST program. He challenges how health systems think about data, integrates clinical outcomes, service delivery metrics, and system context to identify the structural drivers of neonatal mortality. He turns insights into clear, scalable actions using data as a lever for system-wide change. We will see this from the presentation John will be giving us in the next 10 minutes. John, over to you.
Sure, Abiy, many thanks, and happy to meet everyone on this platform as we speak about the journey through a small and sick newborn care dashboard for action and scale. And I wish to turn off my video for the purpose of the bandwidth for now. Thank you. Next slide. I will speak about over this presentation, we'll go over the introduction, speak about a little bit about the Nest 360 and the solution, which is a Nestit, which is a Nest implementation tracker, the data to impact journey, and this is the core part of this presentation, the data use at scale, and also the conclusion. Next. So across many neonatal units that quite a number of you have had an opportunity to work in or even collaborate with, we often have large volumes of data being generated through care and operational processes. However, it's a big question whether those data usually change what happens at the bedside the next day. Traditionally, we know that data always have been reported upwards in more aggregates manner, and very much detached from the frontline decision making. And so the cardinal questions becomes, what if those data could become a daily management tool rather than a reporting requirement? And more to that question is, how could that actually happen? Next slide. So Nest 360 as a Pan-African newborns platform is made up of 23 organizations, and a huge chunk of these are, the 18 of them are in Africa, and it's happening in Ethiopia, Kenya, Tanzania, Malawi, Nigeria, across many hospitals. And it's also very, very strong in supporting in improvement of data systems across countries at national levels and also at facility levels, where we have also been able to support the standardization of individual level data sets, collecting information on health systems and supporting facilities and hospitals and national levels of the health systems to use the data to drive change and also impact. Next slide. Narrowing down to the dashboard, which we call the Nest IT, the Nest Implementation Tracker. This is an online dashboard that we've built over years collaboratively with ministries and hospitals to track newborn care interventions across hospitals, providing structure to accelerate progress for coverage and quality, and also to support identification of gaps and accelerates system changes, including for technologies, staffing, and other system issues. And this is a dashboard that is supporting visualization for more than 700,000 pool admissions. People have logged in more than 100,000 times since 2023, and we are having facilities actively using this at a rate of about 90% for each facility at being able to log into that platform every month. So it's a tool that is really driving change within our hospitals. Next slide. So the journey from care to the impact follows, supported by data, follows a life cycle, and that is of getting the data, and we'll be speaking in details about what that data should be, getting the right insights, getting the right decisions, or doing the right decision, or making the right decisions, and eventually getting the impact. And that journey, when it's closely and keenly closed, then it propagates its repetition. Next slide. What does it take for dashboards to do that work or to enable that, the movement from data to impact? First, we must speak the same language, and that is the building of the common language on indicators, definitions, quality standards, same measurements, and all that. Those dashboards and data need to be accessible, and they need to be accessible at the level of the users. For example, a nurse in a given neonatal unit somewhere in Malawi or in Nigeria probably does not have an access to a laptop, but they should be able to access their data. And when you meet them at their level, probably through a mobile phone, those data need to be understandable, and they should be moving from numbers to narratives. For example, if a person is seeing a line that is going up, going down, it doesn't need statistical rigor or a degree to understand what's going on. So they need to be as easy as possible. Those indicators and data needs to be actionable, and they should be designed for decision making. And so they are not just there as statistics to be reported, but they should be asking the question of, should be leading to a question of what actions do those data lead us to make. And number 5 is the accelerated manner of learning, so that if one place is doing well, it becomes a mentor to another. The experience of one place becomes the knowledge of another place. And so that's one of the those are the kind of the specific features of those dashboards that make them that lead people from moving from data to impact. Next slide. The nested dashboard, as we just mentioned, captures quite an array of indicators running from patient trends and outcome, high-impact clinical interventions, their data on medical devices, data on infrastructure, data on human resources, even data on QI, and even the key aspect of the data itself, which is the quality. And so quite a number of people who are in this platform have access to this, and this will be available even in the near future for anyone across the world. Next. The dashboard has been built with people in mind and has been built for different people to access at different levels. For example, a nurse at a given facility or a doctor in a given facility would be able to access a facility level of the dashboard. And that the usage for that level could be different for a minister at the country level. For example, for a person in the individual facility level may be asking, within my facilities, what patterns do I see for CPAP coverage for symptomatic babies, and how does it differ with another particular feature? For a person at the country level, maybe asking, what patterns of CPAP do we see over time within a country, and which kind of facilities are outliers? And people at the top level, where multi-country data is being put together, they may be asking which country is doing better and how can they advise others on what they've been able to do. And so this kind of structure enables different actions at different levels of access depending on their respective roles. Next. Now let's move into the nitty-gritties of what actually happens. And that at this point, we've moved from the point of data and now to the point of insights. When you have made these data accessible to the people that need to use them, we have an example here of a given facility in a given country, and they've been able to see a chart or a run chart for their CPAP coverage for the eligible babies. And they note something is not happening, and then they dive in to begin interrogating what do these data mean and what do they ask us to do. And so you may have a facility that's have a target, they have not met it. They engage within their newborn units and the labor wards. They uncover some of the fears that could be limiting them from achieving the required coverage for CPAP. In other words, providing the right care to those that need it. And they go ahead to clarify the criteria and even the identification. And through those kind of support, together with mentorship and other people, coverage begins to respond based on the insights they got from the data. And so you need to understand that change, in essence, does not happen in a vacuum. It's really being enabled by QI teams, mentorship teams, the data itself, and even the strong leadership to enable that to happen within that ecosystem. Next slide. That was an example at a facility level. What about at a system level? And here we give you an example of a reality from Malawi, where we observed through data seasonality of hypothermia, and noted that at given months of the year, it used to happen that non-hypothermic or the levels of hypothermia used to go higher at very specific time points. And when people realize this, prior to it happening, they get into action and mobilize resources through the use of the forewarning, beef up their warming chains so that that does not repeat itself. And you can see clearly from the data, the hypothermia levels at the given 2025 period were not as higher than as they were in the previous years. And that's the use of data at a system level. Next slide. The same data leading to decisions and those decisions leading to impact. I'm showing coverage for eligible babies across 4 countries here for CPAP. And you can tell over time, the strengthening of the data systems, the feedback of those data, and also incorporating other relevant teams, for example, biomedical supports to make sure that devices are working, people from the education and training coming together, supply chain is being strengthened. All these you can see change over time, and you can tell, and you know very well, CPAP is a high impact intervention, and that would translate to newborns' lives that have been saved. Next slide. That culture becomes embedded within the systems, and you can tell people are now even annotating charts on their hospital walls. They are viewing they can print their dashboards and pin them on the walls. So that becomes part of the culture, part of the system to driving change, because they are trusting the process, they're trusting the data is responding, the outcomes are responding. So it becomes a motivation even to do it. Next slide. What does it look like at scale? Malawi has been trailblazing us by showing how the possibility of this application and the culture at scale, and we have 37 of the hospitals, the national level hospitals, the district level hospitals, demonstrating this, showing this is very, very much feasible at national scales. And within the Next City Alliance, more hospitals are getting on board. Ethiopia is coming in and scaling this to more than 200 hospitals this year. And so that tells you this is possible to do even at scale. And we also incorporating maternal newborn elements within it so that we can have the diet that leads us to get insights of how to do things from mother to baby. And why is it important really to do this? It's because for each additional facility that comes into the network, it means there's more peer learning and more comparable benchmarking. Regional and national aggregates, they really back those policy decisions because of the evidence, and that also is important for the interoperability with national HMIS systems, as things are not just domiciled within some regions. Next slide. For you and for everyone in the room, if you're a policymaker, the dashboard is not just a monitoring tool, it's a real-time management tool for faster change. For those of you who are practicing and are clinicians by role, your data really drives immediate bedside improvements, plus system changes at hospital and also at regional levels. For those who are implementing programs, go and think about designing for action on high impact care, not just for reporting. Data itself is not the one that saves lives, rather it's the right and timely decisions that do. Thank you.
Thank you so much, John. What a presentation. Thank you so much. I think this dashboard has been built on a big data set, more than 700,000 admission already, and a lot more is coming as countries expand to new facilities. And the most important thing is a dashboard which is made to drive decisions and change at all levels, not only at higher level, at middle level, but the front line where it matters most. Thank you so much. Please continue dropping your questions through the chat. We'll now move to the second presentation. Dr. Siham will be presenting Saving Little Lives Through Data in Action. She's a certified quality improvement advisor and currently quality improvement associate technical advisor for NEST 360 program. And she has a background in medicine and public health and extensive experience in quality. Dr. Sahim, over to you.
Thank you, Dr. Abiy. Good morning, good afternoon, and good evening from wherever you're joining us. I am joining you from Ethiopia, and my presentation today will be focused on one question. Are we initiating CPAP early enough for premature babies? And what happens when facilities actually see and act on their own data? Next slide, please. So, respiratory distress is one of the major contributors to early neonatal mortality, especially amongst premature infants. So, when a baby is born too early, their lungs are not often fully developed, and without respiratory support, survival is significantly compromised. CPAP, or continuous positive airway pressure, is a relatively simple but life-saving intervention. It helps keep the lungs open and improves oxygenation. However, timing is critical. Clinical evidence tells us that initiating CPAP within the first hour of life significantly improves outcomes. Yet, in many hospitals, delays remain common. And this could be due to a number of reasons, including gaps in early identification, communication challenges, clinical decision-making patterns, and so on. So our objective was to evaluate whether the structured data feedback combined with quality improvement and mentorship could improve CPAP timing. Next slide, please. This was a multi-country pre-post analysis conducted across 60 hospitals in Ethiopia, Malawi, and Nigeria. We focused specifically on neonates weighing 1,000 to 1,999 grams who received CPAP. We compared between two periods, which is the pre-intervention period and the post-intervention period. Next slide, please. The interventions included dissemination of the CPAP timing analysis through structured meetings. It also included integration of the CPAP timing indicators into the nested dashboard. As John previously presented, through nested dashboard, facilities can view their own performance trends, the median time, comparison over time, and kind of the progress towards targets. So this visibility allowed teams to monitor performance routinely rather than just retrospectively. And we also had cross-country learnings facilitated through key intervention technical working groups. This slide also illustrates the NEST 360 model for improving quality, the framework we use across countries. The model integrates several components, including reliable data systems, structured quality improvement processes, clinical mentorship, equipment, and learning systems. And these components operate together into a continuous cycle, and it creates a feedback loop that strengthens systems and improves care delivery. So we implemented this model for improvement in all the countries. Thank you. Next slide. So what were the results? Across the 60 hospitals, we observed approximately a 30% reduction in time to CPAP initiation. This result was statistically significant, but beyond statistics, consider the clinical implications. If a baby previously waited 3 hours and now receives CPAP in under 1 hour, there's a meaningful shift in survival probability. And so this suggests that routine data feedback, when structured and supported, can lead to measurable improvements in care delivery. Next slide, please. When we do a country by country deep dive, we can start from Ethiopia, where we saw one of the strongest improvements. The median dropped from 2.22 hours to 0.74 hours, which is really, really amazing. So the question now becomes, what drove this? Why did this happen? And first is Ethiopia implemented a targeted clinical mentorship. So hospitals strengthened on the on-job coaching, focused specifically on early respiratory assessment and rapid CPAP initiation. And secondly, they also had a system-level communication improvement where hospitals created a high-risk notification channel between labor and delivery and then NICU. So if a premature delivery was anticipated, the neonatal team was alerted before birth, and this meant CPAP could be prepared in advance. And this is one of the greatest examples of coordination between the neonatal unit and the labor and delivery unit. Additionally, some hospitals also had structured quality improvement projects focused specifically on improving CPAP and incorporated performance discussions into the collaborative learning sessions where best practices were also shared to other health facilities and can be adopted. That were then adopted. Next slide, please. So in Malawi, median time decreased from 4.38 hours to 3.57 hours. This is also a very significant improvement. It was noticed previously that one factor that contributed to the delay in CPAP is what they called the oxygen first approach, where babies are often placed on nasal oxygen and observed for 30 to 60 minutes before escalating to CPAP, even when the CPAP criteria were already met. So following the dissemination of these findings, the teams engaged the Ministry of Health department leadership to clarify expectations around early CPAP initiation. And also results were disseminated through the hub and spoke model that is currently being implemented in Malawi. And through this hub and spoke model, clinical mentorship visits were also conducted at facility to provide hands-on coaching and reinforce appropriate respiratory decision-making. Improvement plans were also jointly developed between the labor ward and the nursery team to address workflow coordination. So here you can see that improvement involved clarifying clinical practices and strengthening the bedside mentorship as well. Next slide, please. You'll find that in Nigeria, on the contrary, median time increased during the study period. This highlights an important point, which is improvement is not automatic, and system pressures and staffing challenges or workflow barriers can also pose as a challenge to all the interventions that we're providing. Next slide, please. So in conclusion, we see that routing data can drive meaningful improvements when it's structured, visible, and regularly discussed. And it's also important to note that dashboards alone are not are insufficient, right? Data must be embedded within the broader quality model that includes leadership engagement, clinical mentorship, and structured QI approaches. And as you have seen, many delays occur at transition points between delivery and newborn care, and bridging that gap is critical to improving timeliness. I would say in conclusion, ultimately, this multi-country analysis demonstrate that when facilities are supported to monitor their performances and test improvements within a structured model, clinical practice can shift in a way that directly affects survival. Thank you very much. Over to you.
Thank you so much, Dr. Siham. I think this has been very insightful presentation. Yeah, this is a great example of how we can use data to drive change in quality. So having the data alone, not just every data, but good quality data alone is not adequate. We have to do something about it, and this demonstrates the actions that frontline health care providers along with facility managers could take to drive improvement in care quality as well as reduction in mortality. So now we move to our next panelist from India, Dr. Rajesh Mehta. Will be talking about use of point of care quality improvement for neonatal care. Next slide, please. Yes, Dr. Rajesh is an adjunct professor at previous slide, please. At Public Health Foundation of India. He's a coordinator of quality improvement in patient safety international, safety at International Pediatric Association, and former regional advisor for WHO Southeast Asia region. And also earlier, he was a faculty at VM Medical College and Safdarjung Hospital, New Delhi. Safdarjung Hospital is one of the facilities that pioneered the IKMC trial. So happy to have you, Dr. Rajesh. Over to you.
Thank you. Thank you, Abby, and namaste. Moving from Ethiopia to India. Greetings to you from New Delhi, the other part of the world from where I bring you this experience in this journey. When John explained use of data dashboard, and then we had Siham also explaining in the facility, I will illustrate to you how do we use data in action at facility level in a particular way, which we have used in WHO Southeast Asia region in this part of the world. So actually the journey in the region started with this regional framework for improving quality of care for RMNCAH. This was 2015 when MDG phase was ending, and we found that quality has not been the focus during MDG phase. Only coverage was the priority. And when we move into SDGs, I think we'll have to work for quality of care. And soon enough, we had global movement building on this quality of care issue. Next, please. So this framework actually provides us basis for two sets of action. One is at the national level that we set up with the governments, a structure and a process across the leadership from the national and subnational level, which can actually steer and steward the quality improvement processes in the health system. But more importantly, also in a bottoms-up approach, that how do we already make a beginning at the facility level in the hands of the frontline clinical care teams sitting in the facility and trying to use the data locally. And it is surprising that healthcare actually captures a huge stock of data in their day-to-day work, which is actually logged in registers and now more and more in handheld devices. And many times the data is not used for action. So we brought this concept of a problem-solving approach using continuous quality improvement through identifying the problem and then root cause analysis of that problem, and then developing some change ideas and taking them through rapid PDSA cycles to understand whether it is working or not, and then if it works, to sustain and then scale. So basically, we are promoting what the teamwork driven by local data, the improvement part, and how do you, within the available resources, how can you demonstrate a bit of improvement, and then local leadership emerges to take this forward, to ask for more resources and take it forward. So this is called point of care quality improvement, a simplified 4-step process which we promoted. Next, please. So the early users we saw soon after the regional training, a team in Myanmar actually was able to accomplish this aim of 80% newborns receiving immediate essential newborn care at birth in terms of immediate drying, skin-to-skin contact, delayed cord clamping, and initiation of breastfeeding. So they use the local data to find out what's wrong with the care process. And they found that in the root cause analysis, some nurses were unaware of these 4 steps. So they provided training, of course, but some of the data also showed the adherence to this protocol was not there. So all these 4 interventions were not being provided to all babies, and they then put together a checklist. Similarly, clean linen was not available, and they found immediate drying was not possible or not being followed. So the data through a marking that the immediate drying is not happening, and they did a better handover shift. And within 4 weeks, they were able to achieve this aim. So this was early learning for this team as well as in the region. Next, please. And we, promoted this point of care quality improvement, which is based on data for action at a low frequency and dose and high frequency kind of approach. Small number of indicators, but frequently measured, so that we understand whether PDSA cycles are yielding to any improvement or not. So we have seen application of this particular type of quality improvement, continuous quality improvement in India, and it has evolved from small and sick newborn care to pediatric care to also emergency room services, surgery department, cardiology department, ophthalmology department. So the idea was that if you practice POCI, the point of care quality improvement, the same principles are applicable to other healthcare areas within the hospital. And they have now linked the facility-based newborn care training, the clinical training, and they have combined the point of care quality improvement within the clinical training. So the teams, when they come up for clinical training, they also get quality improvement training. And MPDSR, the maternal perinatal death surveillance and response. The response part is clearly triggering quality improvement triggers, and the point of care quality improvement can be used to improve the situation regarding 3 delays or non-compliance to treatment protocols. Bangladesh, similarly, they did in 17 districts. Bhutan is a clear winner because they brought in quality assurance and quality improvement training together, along with coaching in the hospitals, and they have actually introduced point of care quality improvement in postgraduate curriculum of nurses. In Maldives, they have introduced in National Hospital first and then to at all hospitals, and they are trying to use a hub and spoke model that the National Hospital then mentors the quality improvement projects and processes in smaller hospitals. Indonesia, Myanmar, Nepal, Sri Lanka, those are our big countries, and they have practiced this in selected hospitals. But I am happy to report that the model itself had appeal to everyone, and it progressed into other parts of the world through quality, equity, dignity framework. That QED partnership globally evolved, and I think Africa countries also have access to this material. And the document which I have shown here actually captures the first 3 years learning, that how implementation of point of care quality improvement progressed from hospital to hospital and from country to country. Next, please. So with that in mind, that this point of care quality improvement should be a system based and system supported approach. It cannot just be a point of care quality improvement training for a clinical team, that the whole system has to come together. And it is not one-off training in quality improvement that will lead to this kind of approach, and continuous on-the-job supportive supervision or coaching in quality improvement would be required. So we prepared this coaching guide. So it's not just one training, which happens in 1.5 day, but continuous on-the-job coaching is available from the QI experts. And more importantly, then we also have produced a guide that how to, in a district system, you can actually support this quality improvement work by using the systems approach, that in a district they are able to do the QI training, QI coaching, using the data for monitoring what's happening and constantly trying to improve the clinical care. Next, please. So with this package available on website, next, please. I give you two examples. This is a at scale example within a district, 3 or 4 SNCUs or newborn care units working together on similar issues and doing quality improvement projects using POKI approach and leading to a lot of saving in terms of oxygen use and also in terms of rationalizing antibiotics and preventing also retinopathy of prematurity through rationalizing oxygen use and blood products use. This is an example where even mortality reduction was demonstrated in a few states, 125 public health facilities in 6 Indian states coming together. So data in action at facility level, where every day or twice a week, they review their data and make the progress and make the changes to improve the situation. But also within a cohort of hospitals or a network of hospitals, how do you exchange data and benchmark your facilities towards further improvement? Next, please. So it is not easy. We simplified this process, but this 4-step simple process is not simple enough. We still need the health system to come together. We have found these challenges that sustaining QI activities in the hospitals beyond the project phase requires a lot of attention. There is poor motivation. There is no incentive for healthcare teams to continue to do this, and it is considered additional work. Dependence of champions is not bad, but we need each healthcare provider in the front line to become a champion. And inadequate capacity in the system to train people in quality improvement and quality coaching. So dependence on project staff is still there, and the governments must actually invest in this, that there are people who can actually do this. And this so happens that countries are currently giving more attention to accreditation and certification process and not so much on continuous quality improvement. So they use data to actually look at the infrastructure, and continuous improvement actually needs more attention. Next, please. And for a sustaining, we should add this to pre-service education. So my final point is the data in action means that our daily work, we use data to actually identify a quality gap and then use that data to actually monitor the changes which we have brought in to improve the quality of care and constantly try to improve from one level to another. And please remember, bringing infrastructure together, the inputs together, alone does not lead to quality of care. It is the process of care which is critical, for which data use is critically important. So thank you so much. Much more is available on these websites. And I think these websites would be also posted on the chat box. Thank you, and over.
Thank you so much, Dr. Rajesh. I think this has been very insightful. So point of care, using high frequency, low dose approach training followed by coaching, and you have achieved a high newborn care practice. So this is, I think, a great experience for all of us to learn from. And yes, there are system level challenges that are shared across different settings, both in Africa and India, but I think they are surmountable, and that's why we are here also, so we can improve quality through working with this system context. So to the last panelist, but not the least, Dr. Christina Shmuel will be talking about launch of the, can you go back to the previous slide, please? The previous slide. Thank you. Launch of Jaundice Action Pathway. Next slide, please. Yes, Dr. Christina is pediatrician and research assistant with Nest 360 at London School of Hygiene and Tropical Medicine. She has experience in medical education in Malawi and Peru, and also neonatal care in Malawi. So over to you, Dr. Christina.
Perfect. Thank you so much, Dr. Abby, and greetings to everyone from London. We're excited today to share with you the launch of the Neonatal Jaundice Action Pathway as we are considering the use of data in action and the power of QI. So I just want to start with, why did we create action pathways to begin with? Well, the goal is to make it easier to achieve complex systems change for issues which cut across multiple different components of small and SIG newborn care. And we want to do this using existing resources. So we make them more findable in these pathways. And we co-design these pathways with implementers, clinicians, and researchers together for impact. Next slide, please. So this action pathway on neonatal jaundice diagnosis and management was created collaboratively and has been inspired by work with Project Oscar, which aims to reduce the burden of severe neonatal jaundice in Lagos, Nigeria. The work is being done through the Wellbeing Foundation and Nest 360 with funding by Reckitt Foundation. So a special thank you to all of our Project Oscar team members who have contributed to many learnings for this pathway. Next slide, please. So here we have an outline of the neonatal jaundice action pathway. We'll briefly highlight each of the sections today and encourage you all to take a deeper dive into the pathway for more details on the why, the who, the what, and the how, and ways to overcome barriers. Next slide, please. So let's start with the why. Why neonatal jaundice is so important. So, as we know, neonatal jaundice may no longer be responsible for a lot of neonatal deaths, but it contributes to a lot of long-term disability if it's not properly managed. While we worry about things like acute bilirubin encephalopathy in the acute neonatal period, the chronic condition of kernicterus is very concerning as it can lead to lifelong disability. And these are all a result of too much bilirubin in the blood, which affects the brain. We also know that neonatal jaundice has a significant burden, as we can see here, and it's most prevalent in South Asia and parts of Africa. We see on the map the age-adjusted prevalence rates of hemolytic disease and neonatal jaundice from the Global Burdens of Disease study. And we also know that this often correlates with underlying causes such as G6PD deficiency, which is especially prevalent in West Africa and South Asia. Historically, we saw more rhesus isoimmunization that was causing jaundice in the Northern Hemisphere, but this has improved. So we're now kind of shifting the etiologies of neonatal jaundice, but it's still a very significant problem affecting many newborns around the world. Next slide, please. So now that we understand that this is an important issue with significant global burden, we must consider who is part of the team in our hospitals to address neonatal jaundice care and its challenges. So of course, we always start with the newborns and their caregivers, but other key actors in this pathway are healthcare providers, QI and data teams, and we've heard a lot about the power of data in action today, as well as health facility leaders, health systems, and funders. We all have roles to play in improving the care of neonatal jaundice. Next slide, please. Now that we've discussed the why and the who, of course, we need to discuss why the what is very important as well. We know that jaundice is significant. We know what causes it and what works for treating jaundice with phototherapy. But oftentimes the challenge is recognizing jaundice early and knowing how soon is soon enough, but also understanding how high of a bilirubin is too high. Both of these are very tricky issues. We see the bilirubin treatment nomogram on the right, which is familiar to many of us clinicians, but management depends on so many factors. So this pathway aims to help with some of these challenges around the prompt diagnosis and treatment, making sure that we're not getting to the too high and we're treating babies soon enough to prevent complications like kernicterus. Next slide, please. So how do we actually implement quality care? We have 4 steps for implementation, starting with assessing, then planning and implementing, and finally using our data to monitor and evaluate for change. We've collated many resources and tools in the pathway to support this process, including many education and training resources and change packages, such as one created by the NEST 360 team. And we're hopeful that this will really support with implementing the systems change necessary to improve jaundice care. Next slide, please. Finally, in this pathway and in general, we really want to address barriers. And we're highlighting here the significant barrier of delays in care, both at home and in referrals. So some solutions, which are evidence-based, are things like targeting education in the maternity unit before discharge and caregiver education on the newborn wards as well. We also can think about avoiding early discharge and observing babies if risk factors are present, and really focusing on strengthening our referral pathways. And we have resources linked to that in the toolkit as well in this pathway. Next slide, please. So what can each of us do in the next week to actually improve jaundice care in our facilities? Well, there's a lot of options, so we've highlighted a few here. As clinicians, we can learn more about the components of quality jaundice care and many resources and strategies to improve quality of care. We can share the action pathway with colleagues and unit leaders who may benefit from some of the ideas and resources presented. For facility managers, QI teams, and really everyone, we can support early detection so that we catch the neonatal jaundice before it enters the brain and causes complications. Things like caregiver education are critical, as well as staff education on both maternity and newborn wards to promote that early detection. And we really want to work together to plan towards system change, using better data for care and follow-up and investigating underlying causes like G6PD deficiency, which have lifelong impacts. Next slide, please. Finally, we have links to the action pathway here for you all. Please share with your network so we can all work together to improve jaundice care. And we look forward to any feedback on that. Thank you very much for your time. And back to you, Dr. Abiy.
Thank you so much, Dr. Christina. Again, an enlightening presentation, very clear. And we all agree that we want our newborns to thrive beyond survival, and addressing jaundice diagnosis and management is one of the core activities we do in the ward. So thank you so much, all the panelists, all the participants, for the amazing questions you have raised. I think most of the questions have been answered by the panelists. We welcome more questions now, but there is one question that is, I think, in the chat. Maybe, now it is moved to the Q&A. So Natasha asked, Dr. Natasha asked, Dr. Rajesh, you may want to comment. How did you sustain quality improvement work in India, the point of care continuous quality improvement for kids?
Thank you, Natasha, for that attention to detail. You know, we cannot claim that we have been able to sustain all this while. But we actually intentionally made the design of this QI approach, which could sustain itself because it would not need too many resources. So, for example, in the training itself, we designed it to be a very simplified, conceptually very simplified training as a common sense based problem solving approach, promoting the frontline leadership to engage immediately. But to happen that, we actually strategically we made a choice to bring in the clinical leaders. We brought professor level people into our first training, and through them we actually tried to diffuse this down the line, because in our part of the world the medical and healthcare sector is very hierarchical. Whatever the professors do is followed by the lower level hospitals, and the system in public funded hospitals works like this. And then we ensured that the simplified training is effective, but also ensures early success to the teams who are the beginners, and early success motivates them to try more. And also then ministries of health role was critical, that they engaged, and we engaged the partners. Our model is WHO, UNICEF, UNFPA, because they are strong in maternal reproductive health, and USAID as a equal partner, because we were using some of the tools and approaches which they had used much earlier than us. And we together worked and then brought in the governments. Two more things, Abiy, that we also tried hub and spoke model, which is being tried by NEST, and we found medical colleges could, stimulate district hospitals in the neighborhood and support them. Then we established centers of excellence, one in All India Institute of Medical Sciences, where we made the resources available, the technical people available to neighborhood countries in the region, because that's our WHO collaborating center. And we also created a center of excellence in another medical college in Delhi, which also ran a community of practice for us. So they continuously offered people the incentive to come and present their early successes and learn from each other. And last thing, many clinicians found the incentive of publication good enough. And currently, you will see, if you search POCI on a internet PubMed kind of platforms, at least 60, 70 articles would be possible to see where POCI has been used. So these publications also keep our academicians and clinicians in leadership level as an incentive to keep doing this. So these are few things, but still it is a struggle. Pre-service education must incorporate this, and the governments must continue to add QI to clinical trainings. Only then it will become part of our culture. Thank you.
Thank you so much, Dr. Rajesh. Thank you again, all the panelists. And just a quick note. So there will be upcoming webinars. One will be on 10th of March on beta breathing for tiny babies, what next for antenatal corticosteroids and caffeine. And then there will be another on 14th of April, which will discuss about referral system and linkage to maternal care. I think both are very important webinars. We would look forward to your attendance and also inviting others. Next slide, please. Thank you. So this is the last slide. Thank you so much, everyone, again for joining. I don't think there is any question left. So thank you also once more the panelists for the great presentation. The recording will be shared and we'll look forward to you in the future webinars. Thank you so much. Have a good day, evening, morning, wherever you are. Thank you so much.
And thank you, Abiy, for steering us through. Thanks for moderation.
Thank you.